So I'm talking about a little bit on early detection of fetal defects beyond ISUOG guidelines, because what I'm actually going to focus on the fetal heart, a little bit on overview of diagnosing fetal defects in the first trimester, but mainly focus on what Christoph just said, on our work has been in the last 3 years on developing the use of SMI and looking how SMI works in helping us to assess the heart in the first trimester. And I'm going to present to you today the final numbers of our study regarding the use of SMI in the heart. So I'm just going to go through this. You all know with the inversion of the pyramid of care, advocates from Professor Nicolaides, we can now assess a lot of things in the first trimester, and of course fetal defects is one of the things we need to assess. Whatever you do, wherever you are, these are the main things that actually are going to contribute or not with your ability to look at the fetal anatomy. It depends on the time you have for the scan. This is really, really important, because if you have 5 minutes to do a first trimester scan, you don't have high hopes in detecting much things. You need time to do that. Depends on the objectives you have for the scan, and you're just going to see that in a few minutes. For example, if you don't see the hand, you're never going to be able to detect the hand abnormality. Of course, depends on the expertise of each one. If you started scanning yesterday, you shouldn't have high hopes in detecting a lot of abnormalities. So the more expert you are, the more your knowledge are, more you're going to see. Of course, depends on your equipment. Nowadays, you cannot work in very old, you cannot use a 30-year-old machine, ultrasound machine anymore, because the technology have changed so much, and you have so many new technologies that can help you to see better. High-frequency probes, image that is processing in different ways, and many other things that the engineers know that we have actually no idea how it works, but the bottom line is that actually helps you to see the baby better at any stage, especially in the first trimester. And one of the points that are very important is some markers that can help you to think of some abnormalities, and we are going to go through that very quickly. So this is what we do in my unit. This is part of the standard views. We always start with this, if you can see there, yes? We always start with an overview of the baby, and we try to see the whole baby, and decided if we are going to start with the measurement of the markers for an euploidy, like NT, nasal bone, ductus, and tricuspid, depending on the baby's position, or we go to the anatomy. And if you go to the anatomy, we decided to go from the head to the feet, but that's up to you. We start with the head and brain, and then, of course, in the head you need to see the skull. Brain, the most important thing, you need to see the two lateral ventricles with the choroid plexus, symmetrical or not. But the lateral ventricles need to be symmetrical. You need to see the folds, and if you move down towards the neck, you see the thalami and then the posterior fossa with everything. Then we move to the face, and you can see clearly the face at 11 to 13 weeks. Of course, the bigger the baby, easier it is to see. In my unit, we scan the babies. The average gestational age is about 12 weeks. The system works that the patient comes at around 10 weeks for the blood test for the combined screening, and then we book them around 12 weeks, because it's better to see the baby at 50, 54, 60 millimeters than at 45, of course, for the anatomy. And then you can see basically everything. You can see the eyes. Sorry that it goes too fast here. You can see the eyes with the lenses. If you pay attention there, you see the eyes showing up with the lenses. You can also see the nasal bone. You can see the anterior process of the maxilla. There you can see the palate, the anterior palate, and you can see the lips. You can see the nose, nostrils, and everything. And then we move to the thorax. You look at the chest. You can see here the diaphragm. You can see lungs. You can see the rib cage, which is, so those are the things you can see there. And then we move to the heart. The heart is a different session. I'm going to talk a little bit more towards the end, but we look the heart routinely with the B mode and the Doppler, high-definition Doppler, ADF here in the case, and we try to see try to look the heart and assess the heart in a similar way that you do in the second trimester. I'm going to go back to that. And we use SMI to complement the evaluation of the heart. We're going to see that in a minute also. Move to the abdomen and try to see liver, stomach, the position of the stomach, umbilical vein, bowel, when possible, then the bladder and both kidneys. And then I forgot to put here, of course, but you look at the spine and a coronal and a transverse view, and also the finish, we leave at the end, the limbs. This is a basic standard assessment. That's what we do. There are some kind of, you all read a paper from 2011 from the group of Professor Nicolais. They say that there are some abnormalities that you're always going to see, some that you cannot see because actually the structure is not there or whatever makes you see that abnormality is not there yet. The group that actually is most interesting to me is the group that you have potentially, they are potentially detectable. And why is this interesting? Because they depend on how do you see, on learn how to see the abnormality. They will depend on technologies that can help you to see better the structure, and they depend sometimes on markers for abnormalities. I'm just going to discuss this. Learn how to see is important. This is just a comparison. It's not, don't want to say whoever is better. It's just a comparison on what happens when you learn how to see. From this study that I just quoted now, they detected, or we detected at the time, 5% of the cleft palate in the whole data set. And this is not a published study. This is just the numbers that I run in my clinic just to see. And in the last years, we had 9 cases of cleft palate, and in all of them, we detect in the first trimester. What is the difference that is, why is this so big difference? Between 5% to 100%. 5% in 2011 in King's College and 100% in my unit now. It's just that from then on, we learned that how to look, how to assess the face. And one of the things that we used was described by Waldo Sepúlveda a few years ago, many years ago, is to use the retronasal triangle, where you actually see a coronal section of the fetal face. You can do it live scanning, or you can use 3D to do that. And you see here at the top, these are the nasal bones, the anterior process of the maxilla there. And if you have a closed gap there, this is the anterior palate. Yeah, it looks like your palate is fine. And if you have an open gap like this, you probably have a cleft palate. You can have a direct assessment of the palate like this. You can directly see the gaps. You can see the palates there. And you can also see in transverse, in longitudinal view, and you can see what Professor Shawi described a few years ago by looking at the, sorry, it's going to come back here. Hopefully. You can see also the gap in the palate, and you can also find the like there, yeah, you can see there. Yet you can also see the cleft palate. So this is how learn how to see can work for you. Another example is the other way around. In this data set, they saw all cases of the megacystis, while in my unit we detected only 91%. So out of the 12s we had in the last few years, we only detected 11. What was the problem? We didn't use to measure the longest diameter of the bladder. We only actually look at the bladder. And if it was sort of normal, nobody measured. If it was big, we measured. And the one we missed is exactly this case here I show all the time. I didn't miss. Sorry about it. It was not me. I didn't fire the person also who missed them. So he missed this. So he thought that was normal. And then afterward, in the second trimester, was a big bladder. And if you go back and you measure, you see that this is bigger than 7 millimeters. So after that, we start measuring all of the bladders. In a few years, maybe we're never going to reach 100% anymore because we missed one, but we're going to get close to that maybe in the future. Okay? So that's learn how to see and learn how to assess a structure. Markers that can help you. The best example of markers that can help you to assess an abnormality is the example of cardiac abnormalities and the relation with nuchal translucency and ductus venosus and tricuspid regurgitation. If you don't know how to look at the heart, but you know how to do NT, you can use that as your screening test. And you can say, well, everybody that has more than an NT above 95th centile, so I'm going to send it to my cardiologist. If this is your policy, you will detect about 35% of the major cardiac abnormalities for about 5% of false positive rate, which what means that your cardiologist is going to see 5% of your population and is going to detect you are going to detect 35% of the major cardiac abnormalities. And then you are going to ask me, or going to tell me, but that's not really great. Yes? It's 35. It's not really great. Is that great? No great. Are you okay? Everybody's sleeping. No? You're hungry. You want coffee. I'm the person between you and coffee now. So if you answer me, it's much quicker. Okay? So you say 35% is not great. You all agree? Is that not great? But if you do what we do nowadays, so we send to the cardiologist all the people that has a history of cardiac defect. They take some weird medications that increase the risk of cardiac defect. They have a sibling with a cardiac defect or some other stuff. If you do that, if you base on the history, your detection rate is about 10% because only 10% of the population with cardiac defect, they have this sort of history. If you use NT, you increase your detection rate by 3.5 times. So it's much better than only history. But then you can do other things. You can put ductus venosus on your algorithm. And then if you say, well, maybe if the ductus venosus is abnormal or the NT is above the 95th centile, then you increase your detection rate for nearly 50%. And then you do tricuspid regurgitation. And if you use or tricuspid regurgitation or ductus venosus, the inverse A wave, not the PI here yet, or the NT above the 95th centile, you will have nearly 60% detection rate by just barely looking at the heart, not really looking much at the heart. So this is a great example on how to use markers to assess an abnormality and how this can help you to detect more of some abnormalities. But there is place for you to see the heart in the first trimester. This is a study from 2014 from the group of Professor Kate Bilardo that showed that the pool data from many different studies, detection rate for major cardiac abnormalities in the first trimester is somewhere around 80%. So there is, for the ones that like to look at the heart in the first trimester, there is actually a logic in looking at that because you actually can detect major cardiac abnormalities. And when we saw the SMI, I thought that we could use that to increase your detection rate in cardiac abnormalities. But more than that, that can make it easier for you to look at the heart in the first trimester. And that's exactly what you have. We now have finished this study, writing the paper, sending this hopefully for publication. We saw about 2,130 normal pregnancies with 23 cardiac defects. This was done in an unselected low-risk population. This is our demographics. You see the BMI in Portugal is about 26%. People there are slim. They just eat fish. This is the percentage of people that got pregnant from assisted conception. They are sort of young, 32. This is the percentage of history of cardiac defects in the family. This is what I told you earlier. This is 12 weeks is what our mean gestational age. NT, tricuspid, and all these things. But the most important here for me is that 98.8% of the time we've done that with transabdominal probe. There was no need to use the transvaginal probe to assess the heart. And this is what we saw. So to look at the heart, we try to somehow look at the heart the same way regarding the limitations you have, because heart is usually a difficult thing to assess because it's very complex structure that keeps moving. You cannot stop that without killing the baby. So you need to cope with the movement all the time. So we try to look at the four chambers, size, position, and proportion. So likewise you do in the first trimester. And doing that, it's possible without any help of the SMI by just using B mode and color Doppler in about 99% of the time. That's explainable because we are used to do four-chamber view to do tricuspid. So if you just need to learn how to assess the size, how to assess the position, how to assess the proportion so that the two sides are more or less the same, it points to the left and is about 1/3 of the chest, which is very simple. You can do that in 99% of the cases without the use of SMI. So if SMI doesn't add to this view, but it also doesn't disturb. You keep the same 99%. But if you include here, which we didn't include in this study, but maybe in the next study, the assessment of the interventricular septum, you all can tell me that I'm not lying, that it's much easier to see the interventricular septum in the first trimester with SMI. Does anybody not agree with me with that? It's very clear, yes? There is also a possibility, although it doesn't show here in this video, there is also a possibility with the new version of the SMI, I will try to show you there, hopefully, depending on the baby's position, to see the pulmonary veins, which is quite nice to see in the first trimester. So to assess size, proportion, and position, SMI doesn't help. To assess the structures within the heart, it is better using SMI. They don't have this data to show you. The SMI starts helping you when you move to the outflow tracts, and you have here the aorta. We saw aorta where you have a clear connection and septal integrity, the aorta with the left ventricle and a clear integrity of the septum. We saw that in about 71% of the time. SMI helps you to increase to 94% of the time. The same goes for the pulmonary artery, where you need to see the pulmonary artery, the branching of the pulmonary artery, and without SMI, 65%, with SMI, 91%. The same goes for the three-vessel view, where you have to see the three vessels. Most of the time you saw two vessels, even with Doppler, because the overflow, it just hides the SVC. We saw that in 88% of the time, with SMI in about 98% of the time. And the most beautiful thing is that we could see all the structures in one single patient in 81% of the time, with SMI in about 96% of the time. So it really helps you to see better the heart. It is clear and logic to think that will help you also to see, to detect, or at least to select better the cardiac abnormality. So here is our baby. It's a very nice baby. You can thank him later. Okay, so I will start by showing you the heart. Hopefully the baby will still be there. Yeah, more or less. Okay. So four-chamber view of the heart, you need a precise section of the chest, one rib on each side, and then you have there, hopefully the baby will stay there. Oh, baby. Oh. Wow, that's like a roller coaster. Yeah? And I will put just the SMI just for you to see. Yeah, that's SMI. Okay? You can see there, yeah, I'm not lying. Yes, you can see pulmonary veins there. And you can actually see both. Yes? Do you agree with me, all of you? Thank you very much. You can also see interventricular septum. You can see the filling of the two ventricles, and I actually didn't even need to play with the settings. You can play with the settings and make it better, but I'm not going to play with the settings. I'm just going to leave it as it is. And then you can see left outflow tract there, there, yeah? You all agree there. Yeah? You see the interventricular septum. This is the aorta. You can see that is intact. There is no communication there. Little bit of overflow there, but it's because of the gain. It can make it better. And then you can move to whatever the baby is doing now. Pulmonary artery there. There you are. You can see the crossing. Left, the aorta, pulmonary artery, I don't really see the branching here. It's just a matter of insonation angle. You see a little bit there. There's one there going there. Anyway, but you can see there. You can see the aorta, pulmonary artery, and superior vena cava right there. And you can see that really makes your life easier, isn't it? You can even, if you adapt your eyes, it just takes a few seconds for you to do that. You can also see the AV valves and the difference in the implantation of the AV valves. So it's very clear to see. And the heart. Also nice to use SMI for other things, like, for example, everything else that has blood flowing in it. Yes? You can clearly see the ductus venosus there. Do you agree with me? There. I'm not going to measure. And you can see everything that has blood flow, everything that has flow, you can actually see. You can go to the brain. Well, there's three ways to work with SMI. You can use the way I like, which is just using the what's the name of this mode? Yeah, but there is a name. I always forget the name. SMI? The nice mode, let's call it, and then you have the not so nice mode. Yeah, which is. You also prefer the nice mode, isn't it? Yeah, it's nicer. And you can also have it with the B mode together, twin view. Yeah, but I prefer it like this. Once you get used to that, I prefer it like this. Yeah, you can see. Yeah, you can see there everything. The most interesting part is looking at the heart. Is there any question you would like to ask?
Any question? So clear?
Was it so very clear?
Thank you very much. Could you please tell us your false positive rate?
That's interesting. I will tell you. We have, so far, the detection rate for, okay, I was not going to tell this because this was part of the next chapter. You are talking about detection of cardiac abnormalities, isn't it?
Yeah.
False positive rate in detecting cardiac abnormalities, yes? Okay, so our detection rate is 98%. Our false positive rate is 0.1%. Yeah. Our false positive rate is mainly related to disproportion of the ventricles, and our detection rate is mainly because of hypoplastic left heart and hypoplastic right heart, which is an evolving structure, so it's justified actually. Anything you would like to see? Because the baby is really helping me here. Very nice to see.
Okay, there's a question.
Oh.
Twin view?
Twin view, like this?
Yes. Okay, we will show the palette.
You can see the twin view. There, you prefer the twin view.
Jader, there was a question to show the palette.
To show the palette, let's go for the palette.
Doesn't work with SMI, but...
Doesn't work with SMI. I don't know yet. Let me just... We can find a way to use SMI. So there you are. So from the same session you have to see the brain, just go in front of the baby's face. Now the baby went down a little bit. And you have their eyes. And then you go a little bit down and you have the palate there. I will try to show you If the baby, stay there, my friend, little friend. Okay, this is a cross section of the baby's face. Yes, you have their eyes. Let's just put the arrow there. Yeah, you have the baby that is running away from me. And this is a coronal view, sort of. You cannot do this way, yes, but I will try, because now it's how the baby is, I will try to show you this, little bit like completely oblique, but it shows some of the structures there, yeah? This is a coronal view of the baby's face. You have the nasal bone there. This is the anterior process of the maxilla, a bit of the anterior process of the maxilla on the other side. Just imagine that this is the other way around, yes? And this is the base of the pyramid, yes, the triangle. This is the anterior palate. That's how you can assess. The other way, it's how Professor Shawi explained some years ago. It's like this. Well, there is shadowing. The only thing with this view is that you can have a lot of shadow that sometimes makes you think that you have a gap and you don't. Yeah, that's sort of sagittal view. You have the nasal bone, the tip of the nose. I mean, a little bit oblique because you can see the fluid of the lateral ventricle here, but then you have here an intact line, which means that you probably don't have here a cleft palate. I like, but that's what I like. I prefer this view, yes. I think you can clearly see at least the anterior cleft very clearly there. You can see very clearly the anterior palate. You can clearly see that there's no cleft.
Is the contrast okay?
Yeah, it's a bit too much.
Okay, here.
Yeah. So let me just do that. Is it better there?
Yeah.
Yeah, better there. Yeah, there. Yeah, there was too much contrast. So here you have there the palate, intact palate. I really wanted to, but the baby is upside down, so I cannot really have the nice section. Nice. Yeah. It helps there a little bit. Yeah, again, there, anterior process of the maxilla, nasal bones, and there, the anterior palate. Was that what you were hoping to see?
Yeah. Was it okay? Yeah.
Any other thing? You have hands there, nice hands. The baby's waving to us. Look there. Nice fingers, thumb, arm, and the collarbone. You have time? Yeah. Close time? Yeah, okay. And you have lungs. Then you have what we saw already, the heart. You have here nicely the diaphragm. You have nicely there the liver.
So now, at what age do you see the thymus?
At what?
Thymus.
At what age you see the thymus? Well, I mean, it probably from, I don't know, 16 weeks onwards, but I never assessed it in the first trimester, mainly in the second trimester, yeah. Don't know exactly gestational age, but probably from 16 weeks onward, yeah. Then you can see the heart is pointing to the left side, yeah, one more. Okay, yes. So I think we are a bit off on time. I hope you...
Yeah, thank you very much for this.